Hello and good morning, oh, sorry, didn't admit people yet. Good morning, everybody. Thank you, everybody, for joining this morning. My name is Dominic Zerlo, and I'm with the New Mexico Department of Health, and we are here to be able to help support this particular committee. The chair of this committee is Dan Jennings, and so I'll be turning it over to him in a moment. We're just giving people just a minute or so to join on in before we get started. And so just a couple of reminders is we do ask people to please remember to keep language during their comments to be in a non-cuss word whenever possible. And the reason why is because we do want to be able to post these videos. And if there is an inappropriate language, then we are not able to post them, or it takes a lot longer for our communications and marketing to go through to be able to do the appropriate bleeping. So please, please remember to be careful when speaking. And that includes even if, for example, there's a proper name that does have a cuss word in it, please use the abbreviations for it so we can make sure that, we don't have that delay in posting. Other than that, I just want to also thank everybody for being here. We also had found out that there have been some issues regarding the DOH or state servers starting yesterday afternoon. So if individuals did register for some of the other meetings and did not get the response email, you may want to try registering again after today, just because we have discovered that there have been some issues there, and we want to try to reach people as much as we possibly can. So thank you, everybody. And with that, I'll turn it on over to you, Dan. And so the meeting is yours.
Good, and thank you very much, Dominic. Everybody, I appreciate y'all being here again today. And for those of you that are kind of regulars at these meetings, I really appreciate your time and dedication to this. So thank you for being here. Just wanted to kind of just give you kind of a rundown of what our meeting will look like today. We'll kind of start off here with introductions. So just wanted to let everybody give y'all a chance to get in the queue. If you'd like to introduce yourselves, and make sure that you put your hand up. You can always use the Teams feature to put your hand up, and that way you can get into the queue. Whenever you are called on by the team, you will be able to unmute your microphone and be able to speak. So we'll go ahead and kind of do some short introductions with the DOH staff here first, while you guys raise your hand to get in the queue to introduce yourselves.
Okay. And so I'll go on through. Again, my name is Dominic Zerlo, and I'm the Center Director for Medical Cannabis and Psilocybin. Jorge?
Good morning, everyone. My name is Jorge Gonzalez. I am the Program Manager for the Medical Psilocybin Program.
Brenda?
Good morning, everyone. Brenda Martinez. I'm the Deputy Director here at the Center.
Johnny?
Good morning, everyone. I'm Johnny Mouche. I'm a Management Analyst here with the department.
Carmen?
Good morning, everybody. I'm Carmen Batista. I'm a health educator with the program.
And Dr. Truckner?
Good morning, everybody. I'm Robert Truckner. I'm the Medical Director.
Dr. Truckner, just to let you know, your mic seems, I think you may have using a different one.
I just had the boom in the wrong place. So
Okay.
Good morning, everybody. This is Robert Truckner. I'm the Medical Director here at the Department of Health for the Medical Psilocybin and Cannabis Program. Pleasure to be here. Thanks.
Okay. And
Thank y'all, everybody. I appreciate the introductions. And for everybody else that's on the call, remember, please raise your hand to get into the queue so that you can be called on to do your introduction. And just spend about a minute just kind of introducing yourself, your name, your location, where you're coming in from, your affiliation, and if this is your first time of attending this meeting or if you're returning to the meeting. So just a reminder on how to do that. Just click that raise hand button there on the Teams, and then whenever you're called on to unmute, then simply just do the unmute for the microphone button there. There's also the *6 to mute and unmute. And these instructions will be posted throughout the time. So appreciate y'all introducing yourselves.
Charles, your mic has been unmuted. Just unmute yourself and you are able to speak.
Good morning. My name is Charles Cordova from the New Mexico Workers' Compensation Administration. I'm returning to this meeting. We've been attending the other advisory council meetings. The reason that we've been attending these meetings is that we believe there's a chance that medical psilocybin may be covered in workers' compensation based on past findings with medical cannabis. If that happens, we're considering the possible of setting a maximum allowable rate for reimbursement within workers' compensation. And we're attending these meetings to find out what data will be available that would allow us to look into setting rates for medical psilocybin within the workers' compensation industry.
Thank you. Nathan, your mic has been enabled. Speak when you're ready. Unmute yourself. Nathan Rosecrans, your mic has been enabled. Unmute yourself when you're ready to speak.
And just a reminder, in case you are having any difficulties with your tech, you can always drop an introduction into the chat box as well, and we'll read those into the record too. So,
okay, Nathan, we can come back. If sometimes what helps is that people log out and log back in, and sometimes that helps. Ellen, your mic has been enabled. Unmute yourself when you're ready to speak.
Hi, everyone. Thank you. This is my first time attending this meeting, but I've attended a couple of the others. My name is Ellen Schimmels. I'm a psychiatric mental health nurse practitioner in Albuquerque, New Mexico, and I'm a clinical professor at Emory University. I have a background in psychiatric nursing, clinical education, and applied research with a focus on trauma-informed, evidence-based, and ethically grounded care. I'm also an Army veteran. I served 23 years active duty in the Army, as I mentioned, and I have extensive experience integrating research findings into clinical practice, curriculum development, and program evaluation. I've contributed for almost 30 years now, excuse me, in research and quality improvements on mental health outcomes specifically, but also workforce development and patient safety. Happy to be here and happy to be a part of the committee. Thanks.
thank you.
Thank you.
Appreciate it.
Eric, your mic has been enabled. Unmute yourself when you're ready to speak.
All right. My name's Eric Barlow. I'm originally from Idaho. I joined the propagation meeting or committee the other day, but this is the first time for this one, and I don't have any affiliations.
Thank you. Evans, your mic has been enabled. Unmute yourself when you're ready to speak.
My name is Dr. Evans Addo, and I'm a senior economist with the New Mexico Workers' Compensation Administration. As Charles said, we are attending this meeting to look into the possibility of setting maximum allowable rates for the use of medical psilocybin when it's implemented next year. So that is why we are here. And I'm also returning. I've been attending the other advisory council meetings. Thank you.
Thank you. Nathan, your mic has been enabled. Unmute yourself when you're ready to speak.
Al, sorry about that earlier. Looks like my Teams wasn't working quite right. My name is Dr. Nathan Rosecrans. I'm a fourth-year resident in psychiatry here at University of New Mexico. Got a background in science and research as well before med school. And I'm interested in this group in particular because I think whether we like it or not, the mushroom is going to be changed to be optimized in certain ways. And if we're not careful, it's going to end up looking like the way the cannabis plant has been changed, optimized just for THC. And so I think the way that we gather information and the sort of information we focus on, I think can really help shape the future of how we end up relating to the mushroom.
Thank you. Gregory, your mic has been enabled. Please unmute yourself when you're ready to speak.
Good morning, everybody.
Good morning.
My name is Gregory Evans. I am not a doctor. I really appreciate the presence of everybody here today. I am a resident of New Mexico. I live in Santa Fe. I would classify myself as an armchair mycologist, definitely not a professional, but deeply ingrained in genetic mycological work. I have a significant interest in sequencing DNA and tracking wild and new species and known species from wild genetics, as well as breeding known common species like cubensis and others. I have a particular interest in continuing the conversation, understanding where we stand in our current legislation, but building the framework for research that introduces the possibility to identify all of the biomass that we're using in a chemotype framework so that we can better understand what type of what dosage that we're providing people. So the research for that is massive and undone. So I'm here to stand on that soapbox.
Thank you. Aaliyah, your mic has been enabled. Please unmute yourself when you're ready to speak.
Hello, my name is Aaliyah Doty. I'm a doctor of Oriental Medicine in Santa Fe, New Mexico, and I've been to several of the other meetings, a few of the committees, and some of the board meetings, all of the board meetings so far. One of my areas of special training is in nervous system and trauma healing and training and work. And I'm very interested in potentially applying this with psilocybin therapy, and would love to connect with any individuals or groups that are actively in New Mexico that are actively doing research. And I guess that's it. Thanks. Thanks for doing that.
Thank you. Dan, we have some comments and introductions in the chat I will get to. Aaliyah just said, that's great about workers' comp. Excuse me. Matthew Armstrong. Hello, my name is Matthew Armstrong, Ojibwe descendant in East New Mexico. Interested in current research, no affiliations, first meeting. Deb Thorne. Good morning, everyone. My name is Deb Thorne, Doctor of Medical Science and licensed medical provider in Las Cruces. I'm certified and experienced in psilocybin and ketamine therapy. I'm in listening mode only today. I may add to the discussion as I'm able to in between patients. T says, my name is Tay Davis. This is my first meeting, and I'm a New Mexico resident advocate. I'm also interested in current research and how it may be applied to this program. Deb Thorne, and please forgive me if I mispronounce this. Matthew Buzu Anin, sorry. Good to have an Indigenous voice here. And Dominic added some websites here for us, how to reach us, and send an email, any comments, how to look into what the board meetings, minutes, so on and so forth. Here we go. We have some more hands up. Let's see. Eric, your hand is still up. I'm not sure if you wanted to add more. Oh, okay. Let's see. James, your mic has been enabled. Please unmute yourself when you're ready to speak.
Morning, everyone. And Dan, thank you again for chairing this. My name is James Brown. I have a doctorate in pharmacy from the College of New Mexico. I've been trained in Oregon. Today I represent a nonprofit called 5 Degrees North Healing Foundation that is focused on veterans and first responders, especially tier 1, tier 2, tier 3 special ops. Will be reaching out to that community and try to help treat those people. And then as well as Emerald Valley Institute, which is a training program for psilocybin based in Oregon. And I'm going to be bringing them to New Mexico to offer those educational services to the facilitators and also to the New Mexico Department of Health. And I'm here today to let you guys know that we're very excited about this. And my background in research in the past has been with pharmacy and writing therapy plans across the board for hospitals, for health systems. And I'm very excited to be part of this committee. Thank you again.
Thank you. Catherine, your mic has been enabled. Please unmute yourself when you're ready to speak.
Good morning, everyone. My name is Catherine Warnock. I just want to start with lots of gratitude and appreciation for all the people that are here today, especially those that are donating their time and efforts to this amazing project. I am a licensed counselor in Las Cruces, New Mexico. I am trauma informed, and I do have a private practice where I have been utilizing psilocybin-assisted therapy to help people with depression, with anxiety, with end-of-life concerns. And it's been an absolutely amazing medicine. So I'm very excited about all of this. I am here mostly to listen and learn. Wasn't able to attend the last research meeting. I have been attending as many of these meetings as I can. It's very difficult when we all have busy schedules. So I've also been trying to watch the recordings. I just want to stay abreast of everything that's happening and be involved as much as possible. Not sure how much I can contribute to research, but I definitely am here to offer whatever I can. So thank you very much, everybody.
Thank you. Dan, those are all the hands that are up, but we have one more introduction in chat. So Kiana McKenzie, 26-year-old from Oregon, Minnesota, Wisconsin, licensed naturopathic doctor and certified professional midwife, Pecos Wilderness Ranger for 40 years, where I was introduced to plant medicines of the Southern Rockies. We have one more. Good morning. My name is Shane McDaniel. I'm a New Mexico resident. I'm a certified integration coach with cultivation experience, but I am not a professional mycologist by any means. I am extremely thankful for the space. I have been to most of the meetings. Stay warm this weekend. Thank you. We have one more. Aaliyah has one more comment. This is my first meeting with this committee. And that is it, Dan. Over to you.
Appreciate it. Thank you all very much, and for everybody being here, because again, just as Catherine Warnock said, it's like there are a lot of people that are giving up their time today to come to these meetings, and I really appreciate that as well, because kind of centering back on our norms that we talked about from our first meeting, we really feel that in this collaborative space that everybody has wisdom, as that everybody's wisdom can be brought together for the wisest results. So because y'all are here to do this, this is how we can do a fantastic job. I'm honored to be chairing this with y'all. So because of that, each of us will use our voice and allow others to use their voice. We will be hearing others and allow everybody to be heard, avoiding assumptions and ask questions if there's anything for clarification, and reach minimally and act maximally. So we're going to try to take things in chunks so that we can focus on those chunks. I know that this is going to be a wide open range of things to work on, but in order to kind of stay focused, we do want to kind of come to some consensus building for each one of these things that we'll work on. So as we continue to work through the research and continuous improvement committee, will be kind of that ability to flow information back and forth through those different committees as well. So just a couple of things to look at as well from our previous meeting. If you weren't able to be here from our previous meeting, we did bring up some research that already exists. So like I said, I had done some homework, brought some things to the table. I've shared it with everybody and encouraged everybody to send information to the Medical Psilocybin email address to include in with the minutes if there was anything that wanted to be, for example, challenged or changed or anything in the research. I didn't receive anything, so what we're going to do is just kind of bring these up. This is not actually a voting recommendation, just something that we'll always center ourselves around. If you do have information for research and things that would apply to what we're working on here, please feel free to email to the Medical Psilocybin email address. Let me see if I can bring that up here for y'all too. So this is the email address, and just as a reminder for this as well. So instead of just sending like random information to this email address, I would encourage, and thank you very much, Tommy, for dropping it in the chat as well for y'all, to when you send it, if this is for the RACI committee, please put that in the subject line. But if you're going to include any information, like if you're going to include links to things that you would like to include for this minutes, just make sure that you summarize exactly what you mean for that link to include. If you are including a document, if that document can be found on the web, there's no reason to include the document itself as a PDF. You can just include the link. And that way, again, just as a way, instead of saying like, here's a whole bunch of things for you to look at, say that this is something to look at, this particular area, this particular thing, highlight the information that you would like us to see, because then I'll be able to take a look at it and then bring it back to the committee to see if it's something to include into our research bot, if you will. So, Dominic, I hope that kind of summarized some of the things that helps on y'all's side.
It does, Dan, and just so everybody knows, we kind of put that information into the chat as well, including the emails. And a little bit earlier, I had done some of the other websites so that people can see them if you want to go and see. The only thing, just as a reminder, is while our IT in putting things up on the website does as best of a job as they can, they're dealing with it with regard to the entire agency, and especially with legislative session, it can take a little bit. So we just ask, please give it 5 to 10 business days, although it has usually been quicker than that. So we just ask a little bit of grace with regard to that, because it's not just this committee. As many people know, there's 7 committees plus the advisory board. And so we are making our IT staff work very hard in trying to do this. And so we appreciate it. And we do want to hear or get the records. We just, give us a little bit of time to get it up there. So thank you, everybody.
Thanks.
Thank you, Dan.
Yeah, absolutely. And this will be good because we have some time between this meeting and the next meeting that we'll have, which will be March 6th. So just in case you do have anything to add, what right now that we're working on, of course, is some information that we're trying to get to the main advisory board, which will be on propagation and then ultimately on training. We want to get a few of those kind of recommendations stood up immediately. And again, remember that some of this stuff will be standing up frameworks that will be the early phases of the program. So it will have potential to expand in the future, and that's what this committee can help with, is to bring things through it. But at the moment, we're going to focus on helping those other committees stand their recommendations up as well. So just as kind of, I'll go through this. This will also be posted to our meetings page after the meeting. So if you're like, I can't read all this stuff right now, you can definitely take a look at it after it's posted online to click on the links and such. Just a few things I did want to highlight, a few things that are already out there when it comes to code of ethics and equity resources, as well as informed consent and risk screening information that might be helpful, and then harm reduction education. So some of these research items will be focused on for the next work between this meeting and the next meeting. So I just wanted to kind of share that information. Again, if there's any potential research or other things that might be included in this, please share that to the email address so that we can get those included. We can look at, remember, we prefer primary research more than secondary, and this group will also be analyzing some of those research studies to look for bias or anything that might be something that we need to keep an eye out for. So I really appreciate y'all's eyes and thoughts on these kinds of things here. Aaliyah in the comments that said if this committee or anyone has links to some great research, that would be great to be able to access. How do we find these links that you posted on? So yeah, that's one of the things that we want to make sure that we get up after this meeting as this entire body of documents. So thanks, Gregory, for mentioning trying to access some of the box links from the first meeting got 404s. So I'll just kind of let the staff say that after this meeting in the next 5 to 10 days, that this information will be posted for our meeting links and minutes. Okay. So on our next part that we did want to take a look at is the data collection system. So if you're here for our first meeting, I introduced some elements that we could potentially look at for a data collection system for the New Mexico Medical Psilocybin program to help kind of center our ideas around what we wanted to have collecting, especially since this is a medical program and we can utilize this information to help with research. Some of you in your introductions had mentioned that as something that's very interesting to look at and to be thoughtful of. So I'm hoping that as we go through these next couple of slides, I would love to stop at the end of each one of the slides and just let everybody kind of provide whatever comments that you might like to have to challenge an element or to consider other elements that we might need to add into that. So this is where I'd like to provide a little bit more interaction as we go through this so that we can come up with some consensus kind of after every page, if you will. Our first page for data collection would be centered around the patient, the demographics and social determinants for this patient. So going to the fact that we know that the information needs to be very well secured, and we're not looking to collect this information in an unsecure system. The Department of Health has great resources in order to make this happen. So I'll just put that out to preface the beginning. But a patient identifier, notice there's no names or any other things in here, but a patient identifier is utilized, date of birth, sex at birth, because the pharmacokinetics can have an effect on sex at birth. Again, challenge. I'd love to hear thoughts, opinions. Is that something that we need to have in the system? Gender identity, race, ethnicity, tribal affiliation, household income, and veteran status, all for equity inclusion purposes, especially for the zip code as well, so that we know that the medical psilocybin program is accessible through urban and rural areas. So for this first page of data collection elements, of course, things might be added and changed later on. But for today, I would love to open up any discussion if anybody has any thoughts on this information on this page first. And you can definitely use the chat or raise your hands as you did for your introductions in order to make your comments, please. Oh, Jorge, I think you're on mute as well. Let me open your microphone up here real quick.
I got it. I got it. Thank you, Dan. Ellen, your mic has been enabled. Please unmute yourself when you're ready to speak. I'm sorry, Ellen, your mic has been enabled. Please unmute yourself when you're ready to speak.
Oh,
there you
hi.
go.
Can you hear me? Yeah. Sorry.
Yes, we can. Thank
We're
you.
having microphone things. I was just curious. So from a burden of the provider's perspective, I guess I just was curious if you're looking at either creating or having a database that this information would be put in, then that anyone who's seeing anyone and using psilocybin would be that's the intention.
The intention, that is correct. The intention is to have a data collection system to kind of keep track of sessions, to keep track of dosing, to keep track of the medicine as it is created and the COAs come in. So basically a data tracking system so that this is, again, utilized for challenging event research, follow-ups and such. So that's correct. If there's any other, yes, please.
There's some comments in the chat. Let's see if this committee or anyone has links or some great research, that would be great to be able to access. And how do we find these links? You've posted on the website. I can put that in the chat in just a moment. Gregory says, I tried to access some of the Dropbox links from the media and got 404s. I was just looking into that, and I'll see what is going on there. There are people working with psilocybin in the process of dealing with gender dysphoria, and I'd be happy to reach out for comment on how to approach the gender assigned at birth, if that would be useful. Charles Cordova. It might be worth including a data element to identify first responders. Okay, that's all for chats and hands, Dan.
Thank you very much. Charles, thank you very much for recommending first responder element. I would love to open this up a little bit for discussion, especially for you to maybe make some like deeper recommendation on that. And so let me ask, in your idea of what that would look like, would it be a, dare I say, like a true false kind of a field in which the person is identified as a first responder or not, and what would the definition kind of be around that, so we can bring clarification? If you might raise your hand if you wanted to share a little bit more about that, Charles, I would love to hear it too. Thanks.
The reason I'm mentioning this is because first responder status has implications in workers' compensation. As far as a specific data element field is, you could have a yes/no indicator, or you could have an occupation field if you were looking for something more general. An occupation field would enable you to do research to see if there's differences in specific occupations, and how medical psilocybin therapy affects those occupations and the specific requirements that those occupations have for treatment. If you're simply looking for an indicator to say whether or not it's a first responder, and if that has any legal implications, you could just do a yes/no indicator. Anything deeper than that, though, I'm not an expert in this field, and I'm mostly watching these to learn more as opposed to having too much advice to give on it.
Perfect. Thank you very much for clarifying that. Thank you.
Thank you, Charles. There's a couple of there's some comments in the chat. I think age is appropriate, but not date of birth. James says, I have lots of research article links. Please email and with this contact info in there if you're interested. Aaliyah says, for people that are using medical psilocybin, if we want to give info for the research, what about the issue that it's not fully legal to use in New Mexico yet? Question mark. Catherine Warnock says, if we include first responders, would vets might also have specific information that might be available?
Thanks. Appreciate those comments.
Sorry, there's one more that I skipped by accident. This is a new JAMA article out on psilocybin and retreats. I will send link via email. We can include that in the minutes, the link.
Great, thank you.
Thank you.
All right, so
Dan, sorry if I may, I just want to address one of the earlier comments. I'm not sure who had made it, just because there's been so many comments, but they had said they had tried accessing some of the links. If whoever that was who had said that would send us an email to the medical.psilocybin, I'm actually trying to go through myself in those last records, and there are a lot of different links. And so all the ones I've tried so far I've been able to access on a non-DOH. But if you can go ahead and send it through email, whoever had said that, and then we will go ahead and we'll check on those specific links to see what the case may be and how we can correct them. So, and that's the case, by the way, if you're going through those previous records and you run into those issues, just email us at the medical.psilocybin email and we will check into it. As I mentioned in the very beginning of the meeting, sometimes there are issues from a server level that really have nothing that we can't really do very much about, and going and looking a little bit later tends to work as well. But we would like to be aware of it so we can also ask our IT to potentially track down a problem, especially if it persists for more than a brief bit of time. So thank you, everybody. Sorry for that little logistical bit of information.
Thank you, Dominic.
Thank you. And I'll address a couple of these things just so that we can bring these up. Ellen, thank you very much for talking about the DOB part. I can understand where that might be a concern. So my question back to you on this, and then of course, then for the rest of the group to visit on this, is that the specific DOB may not be required, but how about year of birth? Would that be more what you would feel for the research based and for tracking purposes in this be more appropriate? Ellen, I would love to hear your thoughts on that since that was your comment.
Oh yeah, I could just type it in. But yeah, I think that year of birth would make most sense. Thank you.
appreciate you bringing that up. This is exactly why I wanted to have everybody's eyes on this, because that is exactly so. Year of birth instead of DOB. Gotcha. Thank you. Anybody else wanted to push back against that kind of a change? Thank you. Not seeing anything. Then the next one that I did see from Aaliyah was it's not fully legal to use in New Mexico yet. And that is correct because we do not have the regulations stood up, but the law that the bill that was passed is written. So this would be the entire regulatory framework to get it to the point of being legal in New Mexico, because psilocybin would be utilized as a medical program. So that's kind of all the comment that I have necessarily on that one. Catherine's comment on include first responders, would vets also be specific information be valuable? Yes, and that was the reason why it was brought up to add this as a data field or veteran status. Yes, no branch. Again, the comment could be like, do we need to have that specific information? But especially because that was brought up as to be something very specific, we thought we would include it. And to listen on the idea of having the first responders element or maybe an occupation element idea is something that we can definitely kind of bring this up. And Matthew's comment that just popped into the chat with asking first responders to identify themselves, scare some of them away, or this would be an optional field. It's an optional field more for equity and inclusion. So again, some of these things may be the same thing on the occupation. If somebody does not want to divulge, I'm assuming, and this is not a requirement, it is just something for data and research purposes that would be helpful. So I'm assuming that's exactly what that is.
Ellen, Dan, Ellen has another question here. Do we want to consider where they are being referred from?
I'll, if possible, Ellen, would you mind opening your mic and kind of explaining a little bit more about that specific?
Well, and this has come up in some of the other meetings, just really how people can access this treatment. Is it, especially when you might be in something like palliative care or hospice that aren't maybe encouraging, that you do this in any way, or obviously part of that is the education of the community. But I'm just curious if we can kind of find what maybe are more successful or unsuccessful ways that people can be brought into this care. Thanks.
Yeah, and so the referral from would be, in your mind, what kind of an element, what kind of data would be in that referral from element?
Sorry, I wasn't able to unmute again. I was just thinking in the sense of, is it like therapist is recommending this? Is primary care? Are they self-referring? Is there a way to self-refer, when someone just comes in? I'm just curious as to kind of what that process is going to be for patients in general. Thanks.
Thank you. Thanks for clarifying that. I'll be happy to include that as kind of a field that we can take a look at, especially for our next meeting, and to think about what that data might be looking at. And a couple of comments that came in on this. So thank you very much for Dominic, for including this. All items would have the inclusion of prefer not to answer. It's something we always include from our center. Also, participation is always voluntary. So that clarifies that idea of the required fields, optional kind of things there. So that way data could be collected. And then, of course, if it was opted out of, then would not be collected. Catherine, it's important to make this clear. The purpose of collecting the info, since CO made a requirement for vets participating in psilocybin to be reported to the VA. Aaliyah's question was, so for research purposes, not to expose people's names that are using psilocybin medically, can the info be submitted without their name? I was intentional when I created this data element field. If you notice, there's no name on it. So for that specific reason, it is not to track the individual person's name. It's just for the research and reporting purposes here.
There's also, Dominic responded to Aaliyah as well. As it would be an anonymous, unique ID.
Great. So thank you. Any other further comments or questions on just this part? Because there's a few more data elements that I'd like for you to take a look at and then provide some feedback on. Next one, part two of this would be getting some clinical baseline information about this particular record set. First would be primary diagnosis. Built into the bill are 4 very specific ones currently, with the ability to expand as the program grows. But those 4 there have ICD-10 codes that have been identified as a recommendation already from the Patient Qualifications Committee that the board will be looking at to approve for those ICD-10 codes specifically. Couple of the other things that would be in here: diagnosis duration, because just how many months, years has this diagnosis been for the patient? Just so, is this a chronic or is this acute? And especially for treatment-resistant conditions, going into that, treatment history would be something. For example, treatment-resistant depression is one of the patient qualifications at the moment in the law, and so that would be usually identified as 2 or more antidepressants that did not necessarily help with the depression. So therefore, that way we can collect the treatment-resistant status. And then a baseline severity. So based upon things like the PTSD or the end-of-life anxiety or anything else that is part of those patient qualifications, just having a baseline severity score on some of the, and if you're like, what are some of these things? Those are included in the research part just previously. Some of these self-reportable and facilitator-led kind of scale scores that can be put in, especially to see, is the psilocybin treatment helping? So those kind of scale scores could be offered again through the treatment sessions, and to see if it has improved their scores for that baseline. So I'll let anybody kind of comment back on this set of elements while I read into, just raise your hand if you'd like to, and I'll read into from the chat here. Leah, where do we access the data field to fill out for people? Right now, there's no place to access this because, again, we're just building the concept of it. But in the future, when the entire program is stood up, that will be something that does get rolled out for the providers and such that are into this program. And if Dominic wanted to provide any more further specifics on that one, besides that, I welcome.
Yeah, so just as far as that goes, is there'll be a system that we'll be setting up, but yes, that is not yet determined. And a lot of it depends on really what happens within this committee. What is going to be required, what is going to be needed. There's some additional questions. For example, I think the very next one is about whether there's a field for first-time or returning user. I think the answer on that would be yes. We'd want to know, those sort of things. And so once we actually determine that, yes, this is the type of data we need to gather, we'll also be doing a situation where it'll be set up online, so it'll be easy for individuals to access, and that even if the patient may not have computer, smartphone, that sort of thing, the provider will and can assist with regard to that sort of thing. So we want to make sure that's there. And as we get all of the details, that's where like the individual questions will be there. What Dan's really presenting right now is, here are some of the ideas on what some of these are. We have several months to go before this gets established. So as we start moving it forward, ideas are great. And the one thing to also remember is, right now, we're sort of in a stage of what is everything that we want to track. But one of the things that we hear very clearly from not just programs in Oregon, for example, where data collection actually impeded service in many situations, and they're revising that, but also in other programs in the past, where sometimes it sounds great that we want to gather all that information because it's an audience that we can gather everything about, but we have to be very intentional about what that data is, because if it just sits in a file somewhere and is never getting used, there is no point in taking the time to collect it. And so part of what we're looking at is, here's the brainstorm phase, so we're getting everything possible, and then it'll all get whittled down a little bit to what are exactly the parts that are needed. And the other part to remember is, we'll be doing periodically, we will also be doing things like point in time surveys or studies, questionnaires, asking people and looking at that, so that we make sure that maybe some of the questions that we think we should be asking everybody, we really don't necessarily need to ask everybody. Doing a good sampling through research methods is often better than trying to just ask every single person, because it helps us with gathering good data. It helps us with gathering intentional data, and it helps us with reducing the cost of that data gathering, not just from, for example, a department standpoint, but also from the standpoint of time for patients, time for providers. Some of the stories we've heard in the past about many different programs is, yeah, I got to meet with the patient for 20 minutes and then I spent 2 hours doing paperwork. We don't want to have a situation like that. And so please realize right now that's the brainstorm time. We're hearing everything. It will get reduced down. But in that meantime, say what you think might be a good idea, because if nobody else says it, it might get left off when we get to the end. So bring the ideas out. So sorry if it sounds like I'm on a little bit of a soapbox. I'm also a researcher. For those who else don't know, I'm actually my background is in both anthropology and educational psychology, and so researching people, especially when it comes to substance use, treatments, infectious disease, all of that. That's exactly what the types of things I like doing. But we want to make sure that this is getting, that we have a rounded approach and really looking at it from the communities that are involved. And so again, if it sounds like I'm up on a little bit of a soapbox, I am. And but I do apologize. And I'm going to be quiet for really a lot of this, because I don't want to influence what people are trying to bring forward, because again, that's the best way to hear things we wouldn't have thought about. So anyway, sorry, Dan. I know,
No.
quick question, and there I went off for 5 minutes.
No, that's exactly because you've addressed a lot of those kind of concerns that are here, because that's exactly it. We're not today building the system that is going to be rolled out on the first day. The idea here is for us to then analyze this to see if this is something, should we include, should we not include, should it be optional? Is this something that would be helpful for certain practitioners to have? So again, and that's why for those of you that are on here that are facilitators / practitioners, clinicians, those kind of things, I appreciate you being here, because you have eyes on this to say, this is going to be impossible for me to do, or no, that is not going to add to my burden. So that's exactly why we need you here to provide that feedback. Us in the research field, we love to collect everything. There is nothing that we like in having so much data but the idea is that when it becomes the human element, what is the things that are invasive? What are the things that are burdensome? And so thank you for everybody providing those comments back. That's where we need to have that. And so we can comment on this back. And so I'll kind of read back into the record some of the comments that have been coming in the chat.
Sure. I will get to the comments in just a second. I will allow the mic for James.
Thank you.
Your mic is enabled. Please unmute yourself when you're ready to speak.
Thank you again, everyone. Dan, my thought on this is great so far. I know we got more coming here, but with the primary diagnosis and the wording, I just want to make sure with some of the wording that, with cancer, right, it's early, latent, some of the wording might need to I want to make sure we inclusion everybody so that when they do get to the sections, that was my thought on this stuff too, was like, I know it says chronic, and stuff like that, but when you're talking about cancers and stuff, sometimes it's early or latent, or those type of thoughts I was thinking. And then the other thought I was thinking, Dan, was who's going to be administering this or telling the patient to go fill this out? Is that the responsibility where's that responsibility lie? And so that was my other question is that going to be the responsibility of the facilitator, or will that be the responsibility of the specific center, or both? So just thoughts.
Thank you. And I won't be able to specifically answer that since I don't, have the recommendation of, who will be filling this out. So this is just from my thought and standpoint again. So the slings and arrows can come to my brain then. But as a qualifying patient comes into a center or a facilitator, that this information would be gathered on some sort of intake. Again, I'm assuming, again, I'm not a facilitator practitioner, so I can't speak specifically, but I'm assuming if anybody is doing that, there is some form of intake and qualification that is taken place by the facilitator/center for a patient. And so these would be part of those data elements to collect, again, either on a mandatory / or optional basis.
Hey, Dan, I'll read some of the comments, and there are also some hands up. So I will do the chat first. So there was a comment by Shane. Where'd you get this information that Colorado requires vets to be reported? I don't think this is correct, but I could be wrong. And then there were some concerns from Ellen about not to add more, but also something related to intention of the patient in this set of data. I'm also going to read how burdensome this will be to all. Intention, expectations, hopes, and fears. And it sounds like Dominic addressed that. And this is literally your soapbox, maestro, and thank you for holding this. That was from Gregory to Dominic, that's what I'm assuming. He is our maestro, that is. From Nathan, rather than first time or returning user, number of prior treatments might be more useful. And then from Deb, prescriber, I would assume who has a DEA license. And then also from Shane, also, what other medicines have been used in the past and what were the results? And then Nathan added, or at least a mental health provider who is trained to provide these evaluations, such as PHQ-9, etc. And now we'll go back to the hands that were raised. We have Gregory, your mic has been enabled. Please unmute yourself when you're ready to speak.
I think just like layering in some perspective here, and I actually do want to hear Catherine Warnock speak on this because she's been actively doing intakes and recording data over several years. And I know Deb is busy and probably won't be able to talk, but if there's anybody else that's like has actively been doing this, like I think there are layers to it. It's like, and the context of what we decide in further like committees and meetings throughout the year, like who is licensed to do what. I saw a comment about DEA. I don't think, my understanding that we're trying to, manage that ourselves. So we won't, let's say in an ideal world, we're like, we still need to decide if it's a family doctor, a medical doctor, a psychiatrist, a psychologist, or a therapist, or somebody who's otherwise licensed. Like whatever those requirements are will be fit. Somebody says, hey, I think you should engage with this. You may need to talk to this person to get this recommendation, blah, blah, blah. But I think that there's like an initial intake when it's like we start the process. And if the system that we develop is one that is not, hey, it's Tuesday, come in Friday, we're going to blast you off to the next dimension and then let you go about your life. I think like our intention is more one of care and continued support. So like that support being multiple months before of preparation, before a journey as a mechanism of harm reduction. And, just like this is mental health. Like it's not just this one little journey. It's like this big old shift of life. And so it's like those intake forms could be more thoughtful, like for the context of the space, right? So like if I'm going to see a psychiatrist and they're asking me like they just give me the DSM form and I fill it out and I'm like, yeah, I'm depressed today, or whatever, it's like that all just goes in the catalog and nobody looks at it. But if we could incorporate some type of system where vocal recognition like is recorded, is interpreted, emotion, honesty, actual depth of experience. When we're talking about treatment history, who are we talking to? Are we talking to the prescribing clinician, or are we talking to the actual facilitator who has like been through the kind of like the murk? See, I corrected myself. I caught it before it happened. I'm working on it, everyone. I'm trying.
No beeping.
But it's just been through the murk with you. Like your response and honesty with that person is going to be very, very different. And from my perspective, what I want to research is like from the chemicals perspective, what are our inputs? But what I can't collect, the data I can't collect is what is that psychological profile and what is that like emotional capacity that affects any type of journey or even like subperceptual journey, like your
Gregory.
intention.
I'll have to kind of wrap you up here for a second so we
Cut
can
me
get
off.
to the next
That's
person.
good. But does that make sense?
Yeah, it does. And that's why some of this stuff, you're exactly right. We have to say, where does this come from? Does it come from the referral source, the primary physician, psychologist, as such? So, but thanks for bringing that point up there. I think next one is with James for his hands up.
I believe James just forgot to lower his hand, but let's just check. James, did you have an additional comment? Nope. Okay. But we do have one more hand up. Catherine, your mic has been enabled. Please unmute yourself.
Yeah, so unfortunately I stepped away for a second and I came back to Gregory wanting my input. So I apologize for that, but I am looking at the slide. And I will say that I think that would be really helpful is we have a standardized forms there's always problems with standardized forms. So I want to make sure I'm understanding that there needs to be flexibility. But if we can come up with a way to capture some of this information, I think it's really, really important. Assessment is critical. It sounds like diagnosis is going to be really important too in order to qualify somebody into this program. And I will say that it is a process. Like, so what Gregory was referring to is, yes, you don't just like take somebody on and then dose them 2 days later. There's prep work that needs to happen. And the prep work is critical. It's important for the mind, for the set and the setting. It's important for their readiness. You know, there are some people that this medicine is not going to work well with, especially people who have certain, physical conditions that could be contraindicated, as well as readiness, just mental readiness for this type of experience. There's some people that, if you're opening them up at this level and they're not ready, it can actually harm them. So there is an entire process that I believe needs to go, that it needs to be examined. We need to be setting that up properly. I don't think that's for this committee. I think that's probably for another committee, right? Yes, but it is important, all those things. And so, yes, I do think it is going to be very critical to figure out like who are the people that are making the diagnoses. And also I'm, going to be heavily involved in the education committee. And I want to make sure that we have plenty of education around diagnoses so that we're doing it properly. Thanks. I hope that contributed something.
Yeah, and we were really, just because as being a facilitator practitioner, that is the data collection burdensome, that was kind of what I think Gregory was calling out as a recommendation for if you could share everything on too.
Dan, we have one more hand up, but I'm going to go first back to the chat and read those for you. James, on the previous slide, demographic question about what is your state of residence? And then Deb Thorne says you need to have a good medical screening done before prescribing. Additionally, have a good understanding of pharmaceuticals, drug interactions, cardiac and psychiatry knowledge, etc. And then James added also question on, are you able to afford basic necessities for sustainable life? Deb, I have personally worked with patients here in Las Cruces who have had a medically difficult journey here at a local retreat because they were not screened well. This should never happen. Tay Davis, would it be easier to collect at the prescriber level? Question mark. This is mostly information they would collect. And Gregory added on the last one. But to that point, we can collect data that potentially tracks poor decisions in treatment that may have occurred in a patient's past. All right, let's go back to the hands. Unless there's something there you wanted to address, Dan?
No, I appreciate those comments and such. So we'll go to Nathan.
Okay. Nathan, your mic has been enabled. Please unmute yourself when you're ready to speak.
Yeah, this is just in response to who's going to be delivering these measures, like the MADRS or the PCL5, et cetera. It's not, sorry, go ahead.
No, I was, please go ahead on that one.
Oh, yeah. Yeah, so in a sense, it is good to have some training to do it. We have people fill them out at home, kind of before appointments even, but this might be something more for the education committee, but some basic familiarity with the folks who are conducting the ceremonies, because otherwise a patient has to then, after their ceremony or just before their ceremony, they have to then go to their practitioner and have a separate appointment just to get this, MADRS or other kind of measure filled out. So I think it would make the most sense to be able to have the folks conducting the ceremonies kind of delivering these measures, or at least collecting them and inputting them. And then regarding the diagnoses and who's going to be delivering the diagnosis, I think, yeah, it makes sense to have whoever is referring or prescribing in the first place.
Thanks for that.
Thank you. We have a hand up. James, your mic has been enabled. Please unmute yourself when you're ready.
You're ready. Hey, Dan and team, just one thought was we haven't included a question, especially in the front, on the disability. The ACLU would be happy with that. I think we do need to include something about do you have a disability? And then so we just know right away those people need to be covered too. And also that question should be up front.
Thank you. That's it, Dan.
Thank you. I appreciate everybody's comments on these because this will help. What I've been doing with this is taking these ideas and then I incorporate this. You'll see it here in the next couple of slides from some of the data elements of comments that were brought up from the last meeting. So as we get to them, you'll kind of see, we'll bring them back up because this is kind of exactly what we talked about from our last meeting to add or to modify or to change that I've got here in red. So on the session logistics, this would be filled out or completed by the facilitator clinician who is handling the actual administration, linking back the patient identifier and date of session, facilitator license, some kind of tracking on that. For the concomitant medications, that would be for anybody that is on any kind of medications to then kind of track that. And there's a wide range in there for patient safety that committee will be taking, a look at. It's not this committee's responsibility at this moment in time on that, but it definitely will be something that will come up, especially if we're collecting this data on research and there are challenging events that take place after a session and it can be linked back to some sort of a medication, then that would be something to kind of track. The product lot would be tied to the actual psilocybin medicine. The dosage, what was the dosage? And this is measured not in mass of the actual dose, not in like 5 grams, but in the actual milligrams of the psilocin measurement, the MTP definition I'll have to get back to in a second here because I brought that up in another slide. Dosage form, one of the things that was brought up in our last meeting was how was the dose actually prepared and delivered? The administration mode is how was this administered? Was this an individual session? Was this a dyad? Was this a group? And what was the setting type? Is this done in a clinic, a home, or a retreat center? So this is part 1 of 2 slides for the actual session logistics. And I see hands popping up everywhere. So I would love to kind of get your thoughts and ideas on this too.
All right, Dan, let me just read a couple of comments in the chat and then we'll go back to hands. Ellen, what do you mean by poor decisions? You mean ineffective care or less effective care previously, ? And then Charles, also a question, is it possible to get a copy of the slides in the chat? And now we have Nathan. Your mic has been enabled. Please unmute yourself when you're ready.
Great. I like all these questions or all these fields. One concern I do have with the dosage, I think it's a great idea to write down what the dosage of the active molecule is, but because if you're not using like a synthetic or an isolated psilocybin, there's likely other molecules that are having some psychological effect, or if not, any kind of effect at all. So I think it's probably also important to track the lot number, and that will be able to tie us back to whatever strain's being used, but then have an actual mass of that, because there might be some other kind of the entourage effect, et cetera.
Thank you for that comment. Appreciate you thinking on that.
Thank you, Nathan. There are no more hands, but there are some comments in the chat. Kate Hawk says online/at-home ketamine services generally have patients do these assessments online, and then the information is reviewed and discussed in an intake session. And Dominic, responding to the slides. All the slides will be posted to the meeting records within meeting records website within 5 to 10 days of the meeting. And I did post that website earlier in the chat, and I can put that in just a few seconds. All right, we have 2 hands up. Gregory, your mic has been enabled. Please unmute yourself when you're ready.
Will be brief. I just wanted to support what Nathan was suggesting in collecting the full chemobar or the chemotype profile from that session. My specific interest in research is identifying what chemotype can be applied to specific therapies effectively. So like the more detailed analysis we can get in that, the better.
Thank you. Nathan, your hand was still up. Did you want to keep that up? Yeah. Okay. If you wanted to add in more comments, your mic is enabled.
Thanks. Yeah, I did want to add something quick. I'm looking at admin mode and setting type. Given that there's already some like different strategies, different philosophies in how the therapy is delivered, I think it might be worth having a field what therapy modality was used. And I know there's going to be like all kinds of issues with just somebody writing like parts work or anything like that. But as more therapies become kind of developed in this space, as we get more sophisticated, I think it's probably a good idea to track that, so that let's just see, we notice that there's some particular modality that tends to lead to more crises or tend to lead to more something, and we can dig into it and say, I know people are writing this, what does that actually mean? And we can follow up with that.
And before you get your mic off, I do want to is there a change you see, or did you just want to just call out that those are some things that should be included, the admin mode and setting type for that reason?
Yeah, sorry, maybe a separate field that says therapy modality, open parentheses, S, close parentheses, used, and they can fill in like, which modalities. And I would, can
you give me I apologize, I'm very,
yeah.
I'm like, what would be the elements that would be inside of this modality field?
Yeah, so it might be someone might try to encourage someone to do parts work, or because some people, there's some strategies where you just let people have the eye shades on and you put on the headphones, go, and I don't talk to you at all. Others would be more directive. They'll say, lean in, or they, whatever. And the more people do this, the more engaged with it, the more there's going to be a proliferation of different strategies and different modalities. And some probably are going to cause harm or be more risk for somebody who's depressed versus anxious or something. So being able to just briefly, go ahead. What's that, Dan?
I was just going to say is like for a data field like that, I mean, from my standpoint, I just kind of like, for example, admin mode, individual, dyad, group, it would be a drop down. For what you're describing, how would that be like discreetly tracked? What would be those?
Yeah, elements? I mean, what would be, so we have one option would be a list of common modalities with like a little checkbox, but I think just writing in might just be the easiest. And that way, if there's going to be always a lag between innovation and what we're tracking as on our forms. So if it's just a write-in field, someone will be able to write in whatever it is that they're calling it, and we can follow it from there. And I know that's imperfect. I mean, already like in relatively well-defined treatment modalities, we see a lot of differences between practitioners, how they use it, but at least it's a start.
Okay, thank you very much. I just wanted to kind of make sure in my notes that I'm keeping as detailed as I can on that.
Okay, no more hands, but we did have couple of comments. Dominic just added that link once again for the record website, and that will be available in 5 to 10 days, where you can find the meetings, the minutes, the video, and also documents that Dan has provided. And that's true for all the committees. Also, James, question on, what are your current health conditions? Okay. And then Gregory added, for session date, perhaps a diet tracker for past 24 to 48 hours. And we have one hand up. Shane, your mic has been enabled. Please unmute yourself when you're ready to speak.
Yeah, thank you. Another thing that came up whenever I was filling out my forms when I went to Oregon was as part of as an integration coach, and there are times and with sitters or prescribers that some people would have adverse reactions to touch therapy because they don't like to be touched. So we need to make sure we deal with that in the forms so that we don't run into problems with somebody that is triggered by touch. You know, like when I went for Ibogaine, I mean, everybody was hugging everybody else, and and it was just full of, you know, a lot of somatic healing, and some people might have, like I said, adverse reactions to that. So I don't know if that is something we can put in.
Shane, I love that idea. With coming up in a minute, I'll be having the challenging experiences data elements, and if you would keep an eye on that to see if it might help what you're describing there.
Okay, will do.
Thanks, I appreciate that. And so then let's see what our next one is on this one. Okay, so some of these ideas that came up came from the dosing committee as well. So I've added them into this really red background here. But in our last meeting, we were having a suggestion to include prep time as part of the session logistics as well, for how much time the facilitator spent in preparing the patient. Then these next items, again, are something that I would love for y'all to kind of look at as well, and followed by the next ones. Time of administration would be the exact time the dose was ingested, anchors a timeline, time of first onset when the patient or the facilitator notices the first distinct change in perception, time of peak intensity, and time of resolution, ready for discharge. Part of the reason why on dosage was interested on this is because rapid onset, balanced onset, or more delayed onset was one of the things they were interested in seeing on the research side. And again, so I'll let y'all kind of chew on these kind of ideas. And then some of the other things that I included before was utilizing is the session, on using an MEQ 30 score, which was the mystical experience, and then a challenging experience score also. So those are some of the things that would be included in the session logistics part of this data collection as well. So love for y'all's thought on some of those kind of things.
Dan, I'm going to read some comments in the chat.
Yes.
Deb Thorne, good point. I always include a consent for harm reduction counseling and protocols in place. And then Kate Hawk, as we move toward using all our resources, I would very much like to see a way to collect modalities. This might happen during preparation and integration rather than during the closing session. And then Gregory adds, sorry, did I miss administration method? Example, chew, tea, lemon, or ...
So to answer Gregory's, I think that on the dosage form, we could include that in some form or fashion on that, but I see what you're saying on that chew, tea, lemon, the way it was prepped, so.
We have one hand up, Dan.
Thank you.
Nathan, your mic has been enabled.
Those are all really great questions. I think mystical experience score and challenging experience score is to be very useful to have. But those we're starting to get into that whole packet of information that have to be filled out before and after this. And I don't honestly know where I'm coming down. I'm just pointing out the fact that we're looking at a lot of questions now.
Absolutely. And that's why I did want to have these up, because a lot of people have been bringing up, hey, these are some things that we could track. So I'm bringing this to the group to say, here's these elements. And then it's up to, again, this group to come back and say, I'm going to challenge those kind of elements. So that's why I'll still leave them up here. To challenge, to say, no, we have to have this information. No, we don't have to have this for every patient, every session, every client. No, we never have to have this information. This is kind of what this group is all about. So this is y'all's voice.
How comfortable do we feel with making shorter version of these, like a 5-question mystical experience scale or something.
I would be okay with that as long as it was, again, research based. The MEQ 30 has evidence behind it.
Mm-hmm.
So anything that would be, like an MEQ 5 would then have to have, in my opinion, would have to have some kind of correlation between the 30 and the new 5, the same way as some of these other scale scores like the general anxiety, the GAD was based upon a larger element of perception and reality. So anyway, I just wanted to throw that out there.
It sounds like a PhD thesis right there.
Yes.
Yeah, someone's got work out of them. Anyone's looking for one.
Thank you, Nathan. We have some comments in the chat. Let's see, from Shane. Has anyone thought about video recording sessions and the legality or ethics around it? I know that Oregon allows the journey to be recorded, but only to be viewed on site at the treatment locations. Deb adds, many studies use BEX as well. And Dominic, only one, Nathan? And then Deb, BEX department and anxiety score.
Thank you. I was just making a note on that one too. Yeah, thank you. Appreciate that. Yeah.
Depression. She made a correction, added depression, BEX, depression and anxiety score. Yeah. And then we have Nathan with a hand up. Nathan, your mic has been enabled.
Okay. That's raising a good question. Do we need to settle on just one particular depression scale? Because if we've got half our patients using different scales, then that might make the science more difficult. I don't feel qualified to weigh in on whether one is better than the other, but what do you all think?
Nathan, are you answering your own question? I'm sorry, the hand went back up. I like the question because that is a thing to kind of bring up is to do we have to say that this is the scale that you use or I don't know if we can do something like that, but I do understand the correlation between different instruments. But
yeah, I wasn't intending to raise my own hand. I just clicked the button too many times.
Gotcha. I just was like, you needed to add something more to it. So. And then from our last meeting, I was calling this adverse events. And so we've got really great, and I apologize. I would love to give credit where it's due. So if I don't remember, Shane, if it was you or somebody else, but we decided that it was better to call it challenging events. Words do matter on this. So let's kind of consider that as this. So challenging events reporting, and this would be not necessarily linked to the worst case scenarios, but could be any kind of challenging experience that was reported during the session or even after the session. Session identifier links back to the session. Event category is it physiological, psychological, behavioral, a narrative, a severity, using CTCAC kind of guidelines that are out there already for lots of different categories and across a range of from a very light experience to a very tragic experience. The intervention, what was the intervention that was provided? If there is, again, suicidality, that might be something to be looking at, and then duration of and I need to change that AE to CA on there as well for reference back to challenging events. And so this is something that could be utilized for, number one, for reporting, of course, back on sessions. It could be something that raises red flags if there are multitudes of challenging experiences for a specific, whether it be a facilitator, whether it be for certain modality, whether it be a certain lot. All this is researchable information that can be tracked back. So again, going back to the way we've done this, these were a set of fields. Please push back, challenge, add, consider for deletion, whatever that you might think.
Okay, we have one comment from Kate. It looks like it makes sense to do this in multiple stages. Entry of data, entry of personal data by the client, medical assessment, session data, and then follow-up. And we have a couple of hands up. Nathan, your mic has been enabled.
Will there be in this something that the facilitator then knows to contact a mental health professional? So I see the suicidality, for example, right? Is there like a threshold when they're doing the Columbia, the SSRS, if they above a certain level they know to call a clinician, or do we have some kind of mechanism built in there?
I'll say on our side at this moment, this will just be the research data gathering element. However, I do feel what you're bringing up is a very specific thing that makes a lot of sense on and I apologize, I cannot remember every committee that we have. Would that be under the education training, or is there, Dominic, help me out here with what work group that might be best fit with, which would be kind of helping with the facility. I don't know. That's kind of where I'd love to see. I don't think it's in my space here, but I do feel it needs to be, make sure that it's caught by some space.
Yeah, I think that's going to be a part with regard to the training and education for providers. And Greg has a comment there in the chat about administration. Part of some of what's going to have to happen as we roll out the program is going to be, really here's how to utilize the system. So I'll give you an example. Right now, we do the same thing with medical cannabis, where we have the system and we have the different logistical aspects, how patients register, how providers register, those sort of things. And I think that's going to really be a part of, that logistical sort of aspect. Whether that really ends up in training or not, or if that's just a piece that we as Department of Health do, I mean, it'll depend exactly which parts and pieces, but I think it kind of falls within sort of that realm, if that makes sense.
Perfect. Thank you. Yeah.
Okay, we have a hand up. Shane, your mic has been enabled.
Yeah, just want to back up and talk about the adverse reactions versus a difficult or challenging experience. People can have adverse reactions. I'm not saying that that's not the case. But my experience with talking to people and trying to educate people on it is they've heard that somebody had a bad trip or somebody had a difficult journey, right? But after the journey was over, through integration, they received healing. That is a different story than somebody that, say, has a psychotic break or maybe has a my mind just went blank, but has some sort of physical reaction due to like an allergy or something like that. So I'm just saying, I don't want to say that we can't include that there are potential adverse reactions. We just need to be careful that we're not calling difficult or challenging journeys as adverse reactions, if that makes sense.
Absolutely. No, that was why when at the previous meeting it made absolute sense, because when everything is lumped under something called adverse experiences or events, then that does matter. So challenging events does bring into the range of everything that could be something that is challenging, as you said, is like, for example, you could see that the intervention could be there. So could it be verbal de-escalation? Could it be, some kind of other integration? And then that took care of the event, or was it something that would be considered a true adverse event that required EMS transport or something like that? So therefore, this is kind of the entirety of any kind of event that took place during or after the session.
Just a couple of comments. Nathan said, good point. I'll follow up with the training and education. And then FYI, that committee is meeting later today at 1 p.m. And that's led by Brenda Burgard.
Yeah.
And then Gregory added, if you need the link for dose administration clinical practice, he added that in there. Thank you. We have one hand up. James, your mic has been enabled.
Just a couple comments on this. I really like the word challenging event. I didn't know though, when we do have this, if because that's such a broad term and can mean so many different things, Dan, is there a way to like click on that or expand that a little bit? Because I really like the word if we look at the past and what everybody else is doing, just to think about it, that could be a life-threatening adverse health event. It could also be more of a serious health event. So I would just like to see if we could maybe have a definition for people when they do this, when they click that, because I think there's going to be a lot of questions on what's a challenging event.
Yeah.
And so I didn't know if that matters, if we need more definition based on what that challenging event definition would really mean. And then the other thing I had was on the medication, if there is a medication involved, maybe washout. A lot of literature talks about washout period, and maybe have a subsection on that where it pops up, and it has like a washout tab. And did they do a length of time on washout? Was there a washout at all? Because there's a lot of debate about that out there right now, right? So I just thought maybe just expanding on those categories in here. That's all.
No, thank you very much for that one on the washout. Because I know that we have those concomitant medications back on the sessions tab, but there is nothing on the washout. So I know that there is a lot of discussion regarding if somebody's on a very specific medication, that there is a washout period that can make psilocybin effective. So I think that's something to track. Going back to the original, the beginning of the statement that you had, the CTCAC is a wide document used, in oncology. And it's like this document goes from everything from, indigestion, all the way through, unfortunately, death. So therefore, it is a range of different things that it could be. But I do believe that from the standpoint of what a practitioner would be reporting and documenting in there, for example, like Alberta's regulations say, here are things that are trackable, and here are things that are mandatory reportable. So they have guidelines that's kind of say you need to keep track of this, or you need to report this back up to us. So yeah, I think that through the committee process and such, that would be something that we would need to flesh out exactly what you're talking about there.
Dan, a couple of comments in the chat. Thank you, Greg. He added the training and education link, which is for later today. And then Deb added, it really depends on the meds. This can cause more harm. And we have a couple of hands up. Greg, your mic has been enabled.
I would imagine that we'll get to this, but like follow up, like whatever cadence and how much follow up that we can find to like provide resolution. Like some of those resolutions might not happen first in time, and I think that'll be really interesting. But to what the previous speaker was just saying, digging into the adverse or the challenging events type of category is going to be massively interesting, because it's like you can have psychosomatic symptoms, and defining whether those are psychological or physical is going to be a major part in this. Like I've had reports of people having where your body gets cold, hypothermia, where like someone came and checked their temperature, they weren't. It was like fully psychosomatic, and it was this emotional like experience. And being able for the facilitator to decipher between those two things is super important, because if that person gets sent to the hospital, their healing potential could be cut from being able to like really dig into that thing. So I think that this is massive work that I look forward to seeing.
Shane, your mic has been enabled. Please unmute yourself.
Yeah, back to the adverse reaction versus challenging. An adverse reaction, and this kind of did answer James's question. An adverse reaction would be, say we identify contraindicative prescription medications, and somehow they don't get a patient lies or doesn't, whatever, and doesn't include all of their prescription drugs that they're on, and somebody gets through and gets treatment, yet they're on, SSRIs, or they're currently in opiate withdrawal or any of those things. Those could be adverse reactions, right? Where a difficult journey is more of, and for many people during their journeys, experience relived trauma, where it's really not physically harming them, or most likely probably not even mentally harming them. They're just facing repressed memories or something like that, and they receive the healing. It's not easy to watch them go through that. They look, I mean, it could be very, they could look terrified, and it could be very terrifying in the moment. But once the medicine is done, they no longer have the anxiety or the depression or any of the bad effects of those traumatic events in their life, because they received healing and were able to release them. So I don't know if that helps, but I just want to make sure we understand that a difficult journey many times is part of the healing process. It's not a bad thing.
Thank you, Shane. I appreciate that. And the next elements, I think this kind of goes to what Gregory brought up, was follow-up. So this would be a clinical follow-up, patient identifier linking back, the date of integration follow-up, and this could help us measure what the interval was between the session to the next follow-up. Setting type, was this in a clinic all the way through virtual? Depression score, PTSD, some of these different elements that could be administered via facilitator or self-administered, and just I listed a few on there as ideas or elements. And so would love ideas that y'all would like to consider in the clinical outcome / follow-up for the integration phase of a session.
There's one comment in the chat from Eric Baca. They're saying you don't get the experience you want, you get the experience you need. Dan, that's all for the comments and hands that are up at this moment. Oh, here we go. As soon as I speak, there are 3 hands up.
There we go.
All right. Greg, your hand is up. Sorry. Your mic has been enabled. Please unmute when you're ready to speak.
Thank you. I was just typing and I was like, no one's hands up. This may be something that is definitely like practitioner specific, but it could be something that we incorporate into broad state level research. If during the intake process, there is a calculation of intentions, goals, like projections for the overall experience, looking at it from a holistic stance, not just the trip, then in the follow-up, we could track those goals and the progress towards those. Like, I want to feel better about myself. I want to have less depression, and tracking like success rate on specific uniquely identified goals from that patient. But that could just be practitioner based,
Yeah, for tracking in the data element, I would love if you have any ideas, kind of share, maybe like even in the chat, like these are the elements that you could collect in a data element. Like,
Charles, your mic has been enabled. Please unmute yourself when you're ready to speak.
Before I get to my questions, I want to give a little background. Most data collection systems for health information and regulatory reporting are structured around data reports and data elements. A report's typically triggered by a specific event that requires information to be reported, and it consists of a defined set of data elements. In this meeting, it seems like we're focusing on a single report and an event trigger, which would be the completion of an administration session. And then the data elements we've been discussing correspond to those required for an administration session report. On the last 2 slides, I saw a couple of session ID fields, one of which was a patient identifier, and then another of which was a session identifier. Are you considering adding additional data elements that would act as match data for these fields? So for instance, if somebody reports an initial patient ID on their first report, or if you assign one to them, will you have additional fields that have to match if that patient ID is used in the future, so that if the provider makes a mistake and puts the wrong patient ID, that doesn't link future reports to the old to the incorrect patient moving forward in the future? And if so, what type of match data fields would you be looking at for that?
Dan, I can answer this one.
Thanks.
So it's a great question on that, Charles. And we do that, for example, currently in other systems. It'll depend in part on how the system itself gets set up when we get to that point to determine what those match points will be. But that's a great point, and one we definitely do consider when we're setting up those new systems. So thank you for for including that. But yes, we will ensure that there are ways that that can happen, and so that that it is some sort of a method where even if a mistake is made, we're able to correct and to address that. I hope that helps.
Shane has one comment in the chat. Intentions and tracking are part of the integration, pre and post, which is why integration is important. And then we have one hand up. James, your mic has been enabled.
Hey, Dan, just another quick question and comment on this one. And it kind of goes back to the last slide again, just because I have so much thoughts around adverse, things, and I'm completely with the team on do you really need to wash out or not? Is it going to be it's in the literature. There's a lot of stuff out there we need to talk about, a lot of discussion around that. And then the big thing though, for me is we haven't include serotonin syndrome. So if we really look at the most common things that are happening in the research, but also in person, serotonin syndrome should be a drop-down thing, as well as HPPDD. So HPPD is something that needs to be tracked if it does happen with a hallucinogen persisting perception disorder. It can happen, and we need to make sure if these things do happen, that's not their journey, that these things, this is actually a medical condition that has to be addressed, especially being medical providers out there doing this program. They need to be thinking about that, and they're used to documenting that way too. Also, what if there was anything provided besides the intervention, right? So we call it the intervention. What was that rescue? Did they provide medications? There are certain medications that can be provided to help somebody block the receptor, and then that in turn, that journey can be stopped. And so if it's a heart attack or if it's something that's a hypertension issue, was there intervention provided that way? The reason I bring this up is because we have this great database called the Poison Control Center, sorry. And with the Poison Control Center, they're going to get phone calls. They're going to field stuff here, and we need them to track data. And when they do track that data, some of this is going to cross to them, right? And so we want to make sure that whatever we come out with, that they can take that data, because I've been down there, I've done some time in the poison control, and they just need some templates that we can give them and say, when you get these phone calls, put this data in for us and then shoot it over to the Department of Health so that we can include this somehow in another subset for our data. So I just thought we'd capture that as well because it just came up. Those ideas right there. That's all. Thank you.
Before you close that, Mike, HPPD, is that correct?
Yeah, HPPD.
Okay. And
usually we'll give like a benzo or, hopefully you don't have to just set it out, where they're just, kind of like it's been described.
I'm trying to unpeel the onion because I think there were three things I was capturing in what you said. So HPPD was one thing you mentioned. Serotonin, I could not keep in my mind everything you said with it. Serotonin what?
Serotonin syndrome.
And you mentioned for challenging events, capturing, did you say reception?
A rescue. What was the intervention or rescue that was provided?
Okay.
So we get really, thanks. No problem, Dan. Sorry, sometimes I talk too fast. I get nervous.
No,
sorry.
That's okay. That's why I was writing feverishly. And so I was just wanting to make sure that I honored what you mentioned on that one in my notes. So thank you. Perfect.
Thank you, James.
And okay, great. Thanks for Deb for dropping in that link. I'm going to do some research on that one. So thank you.
And Greg has a comment in the chat, just a flag on serotonin syndrome. I'm fairly certain can go digging, but the only reports are when combined with antidepressants. I'm happy to pull that up when I find it.
And then one of the last things, this is brand new, but as we're starting to build out, like, again, the tracking on the actual medicine itself, this is where, and please, this is, don't ask me any questions regarding any of this stuff. This is so beyond my wheelhouse of anything. So I apologize. I'm the wrong person to answer any of this stuff. So this would definitely go to the production, the propagation, the dosing, all those other committees. So please, I would love that. But these were recommendations that were being passed around on those committees. And so, and for the research and continuous improvement, it made sense to include in the data elements. So this table will definitely get built out as things go for certificate of analysis and such, but just some of the things that started to come up for the product a lot, tying that back, because again, the practitioner is going to be utilizing the product would be the measured amount of psilocybin per gram, the measured amount of psilocin per gram, that maximum theoretical psilocin, which is a calculated field, an available psilocin fraction, and then that AFP then leads to what that onset profile category can calculated. And that would allow then for the physical dose to be calculated by the practitioner, decides what lot is best for the onset profile. The practitioner chooses the product, uses a calculated approach then to decide on the best dose, subperceptual all the way up to high. There's ranges that would be probably provided. So the dose weight, we dose desired divided by MTP, record the weight. So again, please, whatever you do, do not ask me any questions to define any of those kind of things, but I just was going to bring them up as a way that could be kept track inside of the system. So Don, go for it, Don.
Okay, great. So Dan, what I would recommend, and I think it's great that you prefaced it as far as this really is sort of falling in under the dosage. I would say to keep this right now just as a placeholder, because as these things get actually determined within the dosage and administration committee, then we can expand this on out. And so I would say this really keep it as a placeholder of sort of what's kind of come out of that committee a little bit so far, but that we really don't spend a lot of time in this group discussing it, just because that's going to happen in that other group, and it would be better to have those balanced discussions there and then import it here when that portion is kind of done. Otherwise, we're going to end up going down all kinds of rabbit holes, quite frankly, on it. Yeah.
Yes, and I've been in all those meetings, and they're fantastic rabbit holes. But for me, I'm just like, okay, this is way beyond my depth. So. So that kind of wraps up kind of the data elements that we've got. So I thank you very much for the comments and the suggestions on everything. What I do is I go back, I make the modifications to those to add in. So at the next meeting, then we can kind of bring again to the consensus over what we discussed in this meeting. So.
All right, Dan, we have one hand up and one comment in the chat. Greg in the chat. For the record, let's get real data on all slides, just hoping we stay clear on the specific realities of risk. We cannot copy/paste from ketamine. And there's a rabbit emoji. And from Charles, your mic has been enabled.
I talked before about triggering events and specific reports, and I had mentioned it seemed like the data elements we've been discussing are all related to the administration session. I wanted to discuss, or at least bring up, if there's going to be additional reports with their own sets of data elements. Two in particular, I'm thinking would be a follow-up report. So if a patient goes in for an administrative session, this report is filled out, and then they do not have subsequent administration sessions, is there going to be some type of report that the healthcare provider is required to file, let's say 3 months, 6 months after the initial session? Because if not, if that patient never goes back, you won't know if the reason they didn't go back is because the treatment was effective, or if it had side effects that were too severe for them to want to continue sessions. Some type of follow-up report so you could know why people are falling out and not going for additional administration sessions could be useful. And then additionally, I was interested to see if any type of billing related reports would be required. For instance, a billing report directly to the patient, or some type of reimbursement or billing report from the producer to the healthcare provider.
So again, Charles, these are great questions, but this is a part of what in the various committees they're going to be making some of those determinations as to what exactly does need to be collected, what reports need to be created, all those sort of things, but they are not yet determined. So we have to kind of see. And as far as for cost of treatment, yes, there's actually been some as far as what the costs in Colorado and in Oregon have been, but it's most likely going to be very different here, dependent upon how our system is set up, because their regulations and everything are very different from ours. So, for example, in both the other states, they have fairly high fees for cultivation, testing, really in various areas, whereas we don't necessarily have those. Although again, that's not yet determined. So we don't have the answers for that yet. But our hope is to be able to have it at much lower cost than the other states are doing right now, because as an example, Department of Health, and for the program standpoint, we're not going to have licensure or permitting fees, but that doesn't mean that it absolves, for example, a cultivator needing to get a permitting fee from New Mexico Department of Agriculture for the correct permits and those sort of things. And we're still working through what some of those are. So those are going to really affect cost. And that's as far as for the medication. And the other part with regard to the administration sessions, that part, because of the federal status of psilocybin being Schedule 1, doesn't look, although again, we're working on that part and trying to go through all the legal aspects as far as for reimbursement, but it does look like the integration sessions, so the therapy sessions, actually may be able to be covered. And so in those cases, that would be covered through, Medicaid, Medicare, insurance, et cetera. But again, we're working on that portion and working on the codes, and a lot of that is being done in the dosage and administration group. So I'd recommend attending that to see a little bit more with regard to it.
And Dominic addressed Dr. Evans's question about the cost of treatment, and Greg dropped in the chat the link for the Equity Access and Cultural Considerations Committee, which is February 4th, 5:15 to 6:30. The chair is Desba. And then we have one hand up. Shane, your mic has been enabled.
Yeah, Dan, I won't ask you any questions on, dosing, but I will say one thing. If we're going to regulate, the amount that we're going to allow for dosing, like I said, in Oregon, it's 5 grams, right? And I do agree with Greg that it depends on the particular, and I'm going to use the word strain because that's what most people call it, although I've been told that it's not really strain. Different strains might have different amounts of psilocin or different amounts of other compounds within the mushroom that we need to measure. But if we regulate that, then we're saying that the ancient healing through indigenous tribes, they don't go out and they don't have chemistry labs to go and look and see how many parts per million of psilocin is in a gram of psilocybin. So if we're going to regulate that, we're kind of tying the hands of the ancestral groups that have been using this for centuries. I think it's more important that we make sure that anybody that is providing it has training on proper dosing in their realm of expertise, but we don't, as a board or a committee, we don't tell people how much they can or can't prescribe.
That's right.
We leave it up to the prescribers.
This committee won't be handling that, but but thank you very much for that. And so I would like to kind of bring this up for our last few minutes here. So we won't have another meeting until March the 6th from 9 to 11. Just wanted to put this out because some of the things that this committee is still responsible for are outcomes, challenging events included, monitoring, reporting recommendations, emergency preparation and response recommendations. Then that would be for the first responders in the community, and then patient community education recommendations as well. And so I would love that if there are people that are on this call that might have some expertise in any of these fields or have ideas that for the next meeting that we'll spend much of the time of the meeting bringing these kind of 3 items up as much as I possibly can during that time period. So I'm going to create, our structure around these kind of 3 things. So I would love for anybody that's on this call, and if you know of anybody that should be part of this meeting to discuss this, to let's start to bring, these 3 things to the forefront so that we can bring some recommendations then to the board for those. So that's really what I just wanted to put that call out to everybody. So as I said in our first meeting that we had a couple of weeks ago, I said this is what, as an educator, I called homework. So this is what for our committee is like the homework that we do. We'll come back to the meeting on March 6th, and I would love to hear y'all's thoughts, opinions, and provide information on these items, and we'll spend the bulk of the time on that. And so that is kind of the time that I wanted to spend with y'all for the things that I needed to get across. This is now kind of the public comment time, if you will, since we have about another 9 minutes left. So I'm going to stop speaking. If anybody does want to speak on any kind of public comment in general, I won't be responding really, but I do want to allow you the 3-minute time period per person to speak on those kinds of things.
And there's one comment from James. Let's see, on outcome side, what about capturing a question on cancer / end of life treatment? Then we have one hand up. Greg, your mic has been enabled.
I'm working on writing this into official public comment that I can send in, but I just want to put future work. I know that this container has been primarily on the clinical research, what can we do with people's experiences and data we can gather there. But once we get kind of further into the year, maybe June, July, August, I would really like to start opening the doors towards what we can start looking at for chemical research and, DNA research, like how we can study the actual biomass that we're utilizing in this practice. Just no response needed. Just wanted to put that on the record.
Thank you.
Of course, anybody else would like to raise your hand or type into the chat box anything that you would like during public comment here. And I'll give 1 more minute to that before I allow, then this meeting could be potentially at the end. So I'll just kind of leave it up to Dominic. Any last thoughts you might have too?
Yeah, I just want to thank everybody for being here and participating. This is really great, and again, really at this point, we're in that brainstorm sort of time frame. And so the ideas are fantastic. Hearing them is great. The one thing I do want to caution everybody regarding is as we move forward with this work, a lot of it does depend on funding. And so, especially from a research standpoint, these are all great ideas, and these are things we would love to implement, especially as things move forward. But funding is a big part of that. And so we will see what occurs with regard to our funding status. I do know, again, and this isn't, by the way, not just funding for the program, I'm talking about just even in general. So one of the other things, if anybody sees things for grants or that possibly could fit in with this, we want to start trying to collect also a repository of where different researchers might potentially be able to reach out to receive funding to do some of this work, even if it is not the program itself, because we are not the be all end all. And I just want to make sure that everybody realizes that. But we want to try to be able to help get the word out there because this is such important work, and it's going to be years down the road before we have some of the items. So if you do have any kind of, as far as links for potential research or funding, again, send it to us through the medical.psilocybin email, and we'll be happy to go ahead and include it in the meeting records. And as I said, as we start moving things forward and have a repository, be able to include it there. So other than that, I don't have anything else.
One hand up, and maybe Gregory has the last comment.
Yeah, Gregory, your mic has been enabled.
Really, I just want to hear more from you, Dom. Specifically, do we have limitations? I have not noticed anything that really limits where we can get funding from. But like, are there any limitations? Are there resources that we can start digging into? And then also as a committee, if we come up with research that we want to that we feel is needed for this program, can we just start writing legislative recommendations? Like part of what we can do is start asking for money, and like years and years out. I would love to see this start now.
So thanks, Greg. That's actually a great question, and I'm actually glad you brought it up. We've brought it up in some of the other committees. As part of an executive agency, we have to go with the executive budget recommendation. So this committee and the board cannot actually do recommendations specifically regarding funding. What I'm talking about is, for example, if there's a grant that comes out from the federal government or from a private entity that would be around this research, then those are the sort of things that could be pursued, or at least we could help amplify that those applications are allowed. But we, as a part of the executive, cannot actually go and talk to the legislature directly, for example, about, would you please fund us for this? That's actually not something that happens. That happens as the budget is created and recommendations are gone through from the executive agencies. However, there was the research fund that was created with the bill last year. It just has not yet been funded. I do know that the primary sponsors were hoping to be able to fund that down the road, but because of our accelerated timeline for the program, that is not a part of for this next year, is my understanding, but maybe for next year. But again, that will be dependent upon what they do. Yes. Research always, it's not just a one-year thing. It really is moving forward in many years. And so that's also a part of why we also look for the outside sources for funding. It's not just funding from internal. And the Department of Health, for example, or HCA and many of the other agencies have a very good track record with applying for grants and for research included from like NIH and, different other federal agencies to be able to do it, including for non-standard treatments. So we would be looking for things like that. And I'm just saying, casting the net. If anybody sees anything on that, it's better for us to get things 5 times than to everybody to say, oh, well, someone else was going to send it, so I won't bother. We would rather get that. And, so we appreciate it. But thank you for asking that question. It's really good. Other than that, and I hate to say this, but we actually have another meeting that several of us have to get to. So I don't see any other hands. Dan, last word to you.
The last word to me is we'll see you all on March the 6th, 9 to 11. So thank you all very much for being here. We'll see you again then. Hope you can spend the time with us. Have a great one.
Thank you.
All right. Thank you all very much. Appreciate it. Y'all have a good rest.